Sir, we are live.
Yeah. Okay.
Yeah. So before we start, I'll just like to introduce us. So just give me a couple of seconds. I'm sharing my screen before that.
Okay.
So is it visible to you, sir?
Yeah,
My
yeah,
screen?
visible. No, no, screen has not come yet.
Okay. Just give
Your
me.
name is visible. We need the slides. No? Yeah.
Is there, no?
Yeah.
Presentations was there. I think. Yeah. Here it is.
I think this.
Yeah. So presentation
Go
is
to the
visible,
first.
sir.
Yeah,
Can you
yeah.
see?
Visible. Right. Yeah.
So
So
from
we can
10 till
start.
you can just start countdown.
Oh,
You
yeah,
can
yeah. We can start. We can
you
start.
can start countdown.
Let
After
us start.
that, we will
Yeah.
start.
So today, good evening all. Today we are going to discuss
So
the much talked about fact that the diabetic macular edema from uh, the treatment angle with anti-VEGFs, from understanding to treatment. So disclaimer slide will be there. Uh, Next slide, the disclaimer side. So these are routine things. Okay, we can skip this one. Next one. So this is much talked about, but we have to impress on the fact that there is expected that the global burden of diabetes will continue to rise. From the chart, it is evident that in North America and Caribbean, it is about going to increase within 25 years of time. That is 33% increase. In South and Central America, it will be 55% increase. And the global burden will be approximately 51% increase within 25 years of time. So what is important for us is Southeast Asia and region, which is shown in the right hand side. That is in 25 years of time, it will be about 74% increase. That is very significant. Now, so we want to discuss about the fact that what is the current scenario. So approximately 80 to 90 million diabetics are living in India, the adult population I mean, and diabetic retinopathy can occur at any stage. So the population at present is
ah,
around 80 to 90 millions, and it may increase to projected
okay.
increase 2030 is about say 100 millions or 10 crores like. Next one. Next slide, please. So, what is diabetic macular edema or DME? DME is the presence of, as we all know, presence of excess fluid in the macula area of the retina can result in loss of visual function. Basically, when blood vessels in the retina leak fluid and proteins in the macula, causing the macula to swell, which in turn affects the visual function. So VEGF, a protein that around molecular weight of around 46 to 48 kilodalton, plays a key role in the pathophysiology of diabetic macular edema. So what did the VEGF-A do? VEGF-A increases vascular permeability and it disrupts the blood retinal barrier in DME, and it is the leading cause of moderate to severe vision loss in patients with diabetes and leading cause of blindness in working age populations in most developed countries. So DME can affect people with both type 1 diabetes mellitus and type 2 mellitus, type 2 diabetes mellitus. Next slide. So vision loss in patients with DME can have life-changing consequences. This a simple chart shows what are the obstacles that are faced by the persons who are affected by diabetes. One is difficulties performing near tasks, increased there is increased mortality risk also compared to the normal vision people, and difficulty in perceiving colors. That is an important thing. Increased risk of also depression compared to normal population. Difficulties obviously in reading near letters and difficulty in driving and so on. So next slide. So what happens if it is not treated early or not adequately treated? So if not untreated, diabetic macular edema can lead to severe visual impairment. So it should be treated early. Diabetic macular, as I already said, diabetic macular edema can occur in individuals at any stage of diabetic retinopathy, and the poor control is obviously very important factor. A patient should be controlled with a glycemic index HbA1c level of 6.5%. That is the optimum level. Below that is also good, but above 6.5%, definitely he or she has to be under control. An untreated DME can lead to severe visual impairment and blindness. And look at the middle figure where the macula is projected as the swelling of the macula initially occurring, and the right hand chart with the yellow circle thing, that is microaneurysm, and the red circle thing, there are sarcinate pattern arranged the hard exudates. Next one. So the treatment patterns that are evolved over time. The anti-VEGF treatment is the current standard of care in the visual impairment due to DME. So there is a long history. There was laser at our hands when we were students in the early internship days. The laser, anti-VEGFs and steroids. The laser performed well, but there is a limited role. Until 2011, it was laser, laser, and laser. Then ranibizumab, the molecule came, and it got approval in 2011, and it was substantiated by the studies like RESTO studies, Rise and Ride studies. So these are studies. Basically, RESTO study was with with laser, and that proves that the ranibizumab is superior to laser treatment. And Rise and Ride compares to the ranibizumab with SAM injections, and the prolonged treatment with ranibizumab fares well. That has been shown in the Rise and Ride study. Then in 2000, that is the evolve, how it evolved. And then fluocinolone acetonide, the long-term drug implant came, and it got its approval in 2012. And there was a FAME study, and it proves that it occurs, it functions well, but there are long-term complications like glaucoma, inducement of cataract. So it was not much in vogue now. Then, with years, dexamethasone implant came. There is a short-term steroid depot injections. As we all know, glaucoma risk is there, but relatively lesser than fluocinolone acetonide. And subsequently, in the same year, as it has been shown by the European approval group, aflibercept was introduced. So when aflibercept was introduced, there are trials, and VIVID and VISTA trials. As we all know, VIVID trials includes populations from European countries, Asian countries, Australia, and the VISTA trial included our United States group. And the primary endpoint in the study is 52 weeks. Then, after a long gap of 8 years or so, faricimab came into vogue, and it was first approved in 2022, and subsequently a new molecule already approved but not in India available. That is aflibercept 8 milligram. Next. So, what factors drive key mechanisms behind the pathogenesis of DME? Next one. So VEGF-A and placental growth factor, that is PIGF, act via VEGF receptors to promote vascular leakage and edema and inflammation and neovascularization. Next one. So VEGF-A and PIGF act via VEGF. VEGF-A acts via VEGF receptor 1 and VEGF receptor 2. Right, right. And the placental growth factor acts both directly via VEGFR1, that is VEGF receptor 1, and indirectly by VEGF receptor 2 by displacing VEGF receptor A from VEGF1. Here it should be mentioned that basically aflibercept is a dimer molecule and a heterodimer, and it is a decoy protein receptor that is around 115 kilodalton in weight and is composed of both from portions of VEGFR1 and VEGFR2 proteins along with the Fc fragment of the human IgG1. Next one. Next slide. So what is the mechanism? Basically, that the activation of PIGF and which leads to basal occlusion and it leads to impaired blood flow, and impaired blood flow leads to hypoxia. Hypoxia again stimulates the BGF, PIGF, and it leads to inflammation in one end, and on the other end that is neovascularization. Inflammation leads to inflammatory cytokine elevations and the binding of the VEGF1 and escalates the inflammation, leading to chronic inflammation, RP cell damage, again vascular leakage and edema. Even the hypoxia directly can lead to vessel leakage and edema. And when vascular permeability increased by the action of VEGF-A, then endothelial cell apoptosis and pericyte drop-off occurred and the opening of the tight junctions and lead to vascular leakage and edema. Next. So aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of retinal disease. So what happens when you introduce brolucizumab, popularly known as brolucizumab, and ranibizumab or its biosimilars? It both blocks VEGF-A, but in case of aflibercept, what it acts to block both VEGF-A, VEGF-B is another protein, also of similar molecular weight of 46 to 48 kilodaltons, and PIGF, placental growth factor, having molecular weight of around 50 kilodaltons. That VEGF-B and PIGF also are blocked by aflibercept, so preventing the inflammatory pathways and so that the level of inflammation and further leakage and edema are much lesser in case of aflibercept. Next one. So, in summary, VEGF-A, VEGF-B, and PIGF are key drivers behind the pathogenesis of DME. Aflibercept is the only globally available anti-VEGF agent that targets multiple mediators of retinal disease. Next one. So, what are the sources of evidence that support the what anti-VEGF we will choose in the real world? So, randomized controlled data are there. There were real-world evidences people study, and the real-world studies are there. There are a lot of meta-analysis. International guidelines are there. Mode of actions of the different anti-VEGFs are there, and patient-to-patient variation on the individual experiences. Next one. Next slide. So there are trials, wide trials that Vivid and Vista with the aflibercept. So that what about the impact of aflibercept in DME? Next one. So these are much discussed that the primary endpoint in the both cases are 52 weeks, that is a 1 year, and if you extend the injections, what are the comparisons with the laser? In both these studies, it has been shown that with the aflibercept injection, the sustained maintenance of visual acuity and anatomical improvements are there. If you extend the treatment after 52 weeks up to 100 to 140 weeks max. So, difference is only thing is that the vivid composed of injections, the persons are composed from people from European countries and Asian countries, Australia, and in case of VISTA trials, there is a population from only the United States. And next one. So vision gains are observed as early with the aflibercept injection, and patient received greater than 8 injections through year 1 and maintained vision gains achieved during the initial loading phase. Across all three studies, patients treated with aflibercept gained on average more than 10 letters. So at that point, I should mention that if you want to use that's the first line of therapy, anti-VEGF as aflibercept should use early. First one is the use it early. You give 3 injections, and then subsequently you can go to PRN basis or treat and extend basis as per your choice or clinical or anatomical improvement in the OCT. So that is very important. Along with the theoretical things, we should look also into the practical aspects of the vision and anatomical improvements. Next one. So these are a long time. If we extend the VIVID and VISTA trials after the primary endpoint, 52 weeks, up to 100 weeks, up to 100 max, up to 140. As I said, the patients in the laser group are eligible to receive aflibercept pro rata basis from week 100 if they met the predefined vision loss and OCT criteria, meaning that there is a very scanty place of laser nowadays in case of diabetic retinopathy, where you have to anti-VEGF treatment is mandatory almost, and among the anti-VEGFs, aflibercept is most useful if you give in the initial loading doses and then follow it up with your PRN or your treat and extend regimes. So 48% and 46% of laser control eyes received aflibercept PRN from week 100 to week 148 in VIVID and VISTA extension trials respectively. Next one. So what do meta? There are a lot of meta-analysis as I told earlier, and expert international guidelines recommend for the treatment of DME. Next one. So systematic meta-analysis of a randomized control trials providing a level 1 evidence-based review of anti-VEGF agents included 24 studies in total, more than 6,000 patients with DME and visual acuity generally between 20 by 200 and 20 by 40. Next. So a Cochrane meta-analysis reviewed evidence from major studies investigating the efficacy of anti-VEGF agents in DME. So there is a systematic random, and the key conclusions. There is the most important thing: the year 1 all efficacy outcomes significantly favored aflibercept over ranibizumab and bevacizumab. Bevacizumab basically is not used in our country now, but in our Western countries still in use. Patients were approximately 30% more likely to gain greater than or equal to 3 lines with aflibercept than with ranibizumab or bevacizumab at year 1. And anti-VEGF did not differ regarding sudden severe acute emergencies at year 1 or year 2 of follow-up, moderate or high certainly evidence. Next one. So other meta-analysis also suggest aflibercept is the most favorable treatment for patients with DME. There are articles from BMC Ophthalmology, there are articles from others, and aflibercept 2 milligram 8 weekly doses consistent with evidence of superiority compared to the ranibizumab 0.5 milligram PRN in the mean change of BCVA, gain of greater or equal to 15 ETDRS letters, and loss of greater or equal to 10 ETDRS letters from baseline. In other one, aflibercept is the most favorable treatment in terms of BCVA improvement and CMT reduction, central macular thickness reduction, compared with other therapies in the management of DME within 12 months. Next one. So international guidelines and recommendations suggest Aflibercept should be the drug of choice in patients with BCVA greater than 16, less than 69 liters. Less than 69 liters. These are the next one. I think the next one will be more useful. Next slide, please. So these are the different guidelines. That is important. That EURETINA guidelines 2017. That all these the substance is that basically if you got the baseline low vision, start with aflibercept early. That is the main thing. If you have got the patient with baseline low vision, start with aflibercept early. Give the initial loading dose. Follow it up with the vision and anatomical improvement with OCT, and you can extend, treat and extend depending on the response and vision of the patient. And so the different guidelines say also the similar things from German guidelines or the Canada diabetic guidelines. So there is a evidence for possible difference in drug efficacy in patients with diabetic macular edema to the disadvantage of bevacizumab at a visual acuity of less or equal to 20/50. Other Canada guidelines also says that at year 2, the gains of 18.1 liters in aflibercept, 13.3 liters in bevacizumab, and 16.1 liters in ranibizumab. So overall, aflibercept, the patients who received aflibercept with the vision gain is most among the all three. Next. So can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? That is a question. And next slide can give the answer. So data from Moorfields Eye Hospital and the 5 Tetina Blindness Registry assess the efficacy of aflibercept in patients with clinical practice from baseline to 12 months, and adjusted mean change in visual acuity among patients with less than 68 ETDRS status, meaning 20 by 40 or worse than baseline. So poor baseline visual acuity is commonplace in up to two-thirds of patients in clinical practice, where the importance of aflibercept is more than ranibizumab or bevacizumab. Next one. So there is another modality that is very interesting. If, what happens if after the initial loading dose we can adjust and alter the dose. There is a variable interval bolus injection model that is separate, but very interesting. That you give the loading doses monthly or 1.5 months, and the aflibercept initiated in year 1 can provide clinically meaningful outcomes, visual outcomes over the next year. At the end of 2 years, it has been studied. If it is at the end of year 1, 9.1 ETDRS letters, at the end of year 2, it will approximate 9.4 ETDRS letters. So here, what you are doing, that you are adjusting and extending, if it is possible, with the vision, improved vision and anatomical outcomes. So you can increase the dosage interval. So it may be possible to increase the interval by 2 months, even up to 3 months or 12 weekly. That 57% of patients were on greater than or equal to Q12 treatment intervals at the end of year 2. Next one. So there are studies, Hirano et al. Studied the majority of patients with DME achieved 16-week treatment intervals with an individualist treat and extend regime with aflibercept initiated in year 1. So here the population of patients are low, but 75% of the patients improved fare well with the increasing interval of injection of 4 months, that is 16 weeks. Next one. So there is another trial where you are inviting cases, people who are not responding to other anti-VEGFs, and there also, if a BPM method is followed, then it can be seen that 89% of patients had a last injection interval of at around 12 weeks or 3 months. There is a chart showing that the 12 weeks interval is is made possible in case of aflibercept injection in 14 number of patients, where 8 weeks in 2 number of patients and 4 weeks interval in 3 number of cases. So mean number of injections over 52 weeks here is 7.7. Proportion of patients who reached disease stability at week 20 and could begin interval extension is 87%, and proportion of patients with a dry retina at week 52, that is at 1 year, is 51%. So in summary, aflibercept, I think, is the last slide. Aflibercept can achieve a meaningful vision gains in patients with DME, as demonstrated by randomized control trials, meta-analysis, international guidelines, and recommendations suggest aflibercept should be the drug of choice when treating patients with baseline visual acuity less than 69 letters. Mind you, very important it is in the ETDRS chart. If it is less than 69 letters, treat with aflibercept. So, highlights the effectiveness of aflibercept in the clinic. Patients regularly present with poor baseline visual acuity less than 69 letters. So, in summary, patients with visual impairment due to diabetic macular edema, particularly those with baseline visual uh, acuity less than 69 letters or 20 by 40 or worse, can achieve meaningful visual gains with aflibercept compared with other anti-VEGF agents in real-world clinical practice. Thank you.
Okay. Thank you so much, sir. Thank you for the wonderful, insightful presentation. So with this, I think we are open to like take questions or query from audience.
This is completed. I think.
Yeah, yeah,
Yeah,
it's done. So
yeah.
with this, we are good to take any query or doubt from the audience. If there is so, we're open to take query.
Okay.
So if no query from the audience end, that's great. And great. I think it's good to like close the call in that case. So thank you so much, sir. Thank you once again for the
Thank you, audience, and thank you.
thank
Also,
you
thank
everyone
you
for joining us and
everyone for joining,
wow.
making that successful. I think more and more people should join. Also, thank you,
Thank you so much, sir.
thank you, thank you.
Good night. Good night. Good night, everyone.
Good night.